Hello, social workers, mental health professionals, and change agents. Welcome to another episode of season 10 of the Social Work Ranch podcast. I'm your host, Bash Moreno. Saludos a todos. Greetings, everybody. Thank you for tuning in, tapping in wherever you are watching or listening to this podcast. Appreciate all the love support. Continue to follow the podcast along on Instagram at the Social Work Ranch podcast. Um, and yet, before we get started with this week's episode, this do the disclaimer: this episode, while the podcast is not to be used as a substitute for individual counseling and therapy. If you have a therapist, call your therapist. If you have a psychiatrist, call your psychiatrist. Call 988. Call 911 if it's a real emergency. For all my listeners and viewers out of the United States, whatever your emergency line is, use that. It's okay not to be okay, but definitely get the help that you need. It's Pride Month, so happy Pride Month to everybody who celebrates. Is also Men's Mental Health Month, so definitely get the help that you need. And enough of this man up nonsense. And it's okay to cry if you need to cry. Like, I've definitely been going through it. Just all of May has been rough. So, and now we in June. So, my guest at this time, Rosita Marinez, fellow co-author of the award-winning Latinx and Social Work Volume 2. If you haven't gotten that book, definitely go get it. Um, this is like your fourth time already?
No, I think it's my fifth time. Thank you again, Baz. It's my fifth time.
Oh, I gotta go back because
Yeah,
see,
you have a whole
um,
collection in terms of the housing. Yeah, we started with myself, then with mentorship with Nelson, that was Shams, then with Kenya. Now we're here, um,
oh snap!
yeah,
So
with myself solo.
we got
Yeah.
it. So we got gotta get you to do the Booker T the 5 time.
The five time, the Booker T five time. Yeah, this is my fifth time, and I really enjoy coming back to your podcast, and being able to reconnect and also talk about like real topics and be able to, have a voice and expression without, all the other underlining things. So thank you again for your invitation.
No, yeah, of course. No, every time we get a chance to talk about housing is definitely an important topic. I think it's good for new MSW graduates
Hmm.
or you just new in your career, a couple of years in, and it's a good area to get into. For experience, you get to learn a whole lot of different things and
Yep.
even some policy work. Even if you're doing like case management stuff, just learning different things and yeah, it's definitely learned a lot. Doing scattered site housing for a few years and learning other different things and how programs get funded through
Hmm.
working in New York and yeah, so yeah, so it's a whole lot to learn. So definitely look into it, that these different agencies is good out there. And of course, housing is in the U.S. is becoming unaffordable very, very quickly on a daily basis. So it's an important topic that we touched on many times on the podcast.
Yeah, absolutely. Now that you're saying, because it is graduation month, right? We started, well, not well, it started in May and now we're in June, right? For all those new graduates, either BSW, MSW, that want to enter the profession and be ground on the boots and learn the different areas of practice, going from clinical, operation, programmatic, housing. I definitely recommend because it will prepare you for anything, as you know, um, as anything else that you do down the pipeline in your career. It's working with the clients in the community or in a residential setting. It's working with also the funding source, wraparound services, everything that you actually need in terms of really, wanting to expand in whatever area in your career down the pipeline. So definitely recommended. Number one. Number two is we are always in need of uh, community-based social workers, right? I know a
Mhm.
lot of people want to go into clinical, which is great, but there is a service gap for our clients, our community members in terms of social workers and bridging the gap of services.
Oh yeah, absolutely, and and depending where you work at, the pay is not terrible. So if you're lucky, so definitely want to get to program management, like whatever you want to do.
Mhm.
There's a whole gamut of stuff that you could do in terms of housing, and luckily you work in New York, and there's definitely a whole bunch of housing programs. And unfortunately, the state that I live in, we don't even have a housing program. So it's like,
Yeah.
depending on state by state basis. So I know you've been working on a program that we want to talk to about health connects, and the objectives of that program. Like, just let people know what's it about.
Yeah, so one is that, yes, like you mentioned, in New York City, the beauty is that we have, the funding source, we have different providers, public, nonprofit, private, where, the investment is in there in terms of housing first model. Unfortunate, other states like Delaware, New Jersey still is struggling in terms of really, having affordable housing and supportive housing programs that are, affordable in number one in rep, but also with the wraparound services needed. So in saying that, yes, so the past, I would say 2 years, I've been working on a new innovative program that I actually saw the need way before my tenure as a senior vice president, that I've actually seen throughout my career in housing. So I've been doing housing for 16 years, from low income housing tax credit, residential, to scatter site, transitional, every level of housing. I've actually been blessed, and I'm saying that to kind of like see the different portfolios and funding source from federal, state to city. Is I always saw a gap, especially in scatter site housing. So what is scatter site housing for our audience that don't really know housing or understand how it works? Is that scatter site was a model that was roughly launched about 30, I would say about 20 plus years, in terms of having individuals live more in the community than just a building that's set aside for individuals with um, disabilities. With that being said, it's the model is providers would be renting out, leasing apartments in the community to any landlord. So I could go out there, rent a couple of apartments for individuals with a disability, and the disability would be either serious mental illness, substance use, or better yet, chronically homeless or unstably housed, right? So that
Hmm.
model is helping people to integrate more into the community than just residential or supportive housing, low income tax credit buildings. With that being said, it's a good model in the sense that, hey, it's not a building standing alone where it is identified by the public saying, hey, these are the people who are chronically homeless or unstably housed, and identify it. It's more about integrating them into the community like everyone else. And what
Hmm.
does everyone else mean? Because we all have issues, things and
Hmm.
issues that we go through, right? So with that
Hmm.
being said, is that scatter site model, we get funding from either the federal government, the state, or the city. You lease up apartments from studios to one bedrooms, 2 to 3, and individuals who are coming either from the shelter, unstably housed, or institutions, get admitted to our housing and then placed in the community. And that would be more the permanent supported housing, meaning this is their permanent placement. With that being said, is depending on their income, which could be from working, SSI, SSD, you would pay 30%, and then the program pays the rent of the allocation. And then the person is assigned to a case manager, minimum of once a month home visits, and then really follow up on their care plan or service plan of the goals that they want to work on, and then really connecting them to hopefully wraparound services of mental health, care coordination, if they need SUD services, pros, whatever is needed, connecting them to those wraparound services. With that being said, as people age in place and then integrate themselves in the community, individuals start aging in place. Also, their mental health might deteriorate because of lack of follow up with their provider, meaning psych, or even with their medical provider in terms of their health. Isolation, which this has been known, especially during COVID, where us human beings,
Mm-hmm.
need that human connection, but especially with individuals with SMI are even more isolated from their family, the communities, and have that support. So, in saying that, is there's a lot of many times what happens is a lot of service gap and disconnection. We see it as the person, got a placement, but better yet, has a home, is in the community, is thriving. Well, many times that doesn't happen in terms of the thriving and connection to services and that level
Mm-hmm.
of support needed in terms of isolation. So I have been seeing that for a long time, and I always said, you know what, we need like a clinical specialized team that focuses on individuals who are in that higher need of services, meaning more high risk to one in terms of overdoses, two in terms of reincarceration, right? Three, those with chronic medical conditions, and four, really in terms of their mental health, right? If they have, lapse of treatment, non-compliance to medication, someone with schizophrenia or bipolar or schizoaffective disorder, what happens, right? That may trigger other things. With that being said, seeing the disconnection there is where this program comes into place, where it's a clinical specialized team with a social worker, LCSW. We have more two MSWs. We have peers with lived experience, occupational therapists, a nurse, right? In order to provide, also now an occupational therapist, I think I mentioned, to provide that level of assessment, referral, de-escalation, be part of that gap service of when individuals are discharged from the hospital, be part of the case planning. If individuals are having an episode, in terms of hallucination and things like that, that they are meeting with the team in order to assess and provide that whatever next steps it is in their care. So really, it's more an integrated behavioral health service directly with individuals living in scatter site model, which is in the community. So this little mobile team, it's not that big, altogether about 8. They all work in a team modality and go into the community and meet with clients and provide that level of service. And so the objective is to bridge the gap between the housing stability and mental health in order to deliver that on-site type of crisis intervention and also follow referrals, follow-up, and wraparound services. With that being said, they don't work alone. They work with the housing case management team. So everybody who lives in housing, scatter site, or even in residential has a worker, either a counselor or case manager.
Mm-hmm.
So the Health Connect team works with the housing team to provide the follow-up to ensure that we're part of if the person's in the hospital, ensuring that we follow up, part of the discharge planning, and work with the housing team in order to provide that clinical level of intervention, follow up, and then with outcomes. So it's really to, number one, decrease hospitalization, medical and psych, decrease overdoses with harm reduction and education, and of course the person's willingness, but that takes time. And then three, in terms of medical, right? If someone is not connected to a doctor or needs more preventive care, so the nurse would be there to do an assessment. And then peers. I always say peers are very important because the individual can connect and get that level of peer support than someone that doesn't have lived experience. So it's really like a combination of all those areas in order for us to stabilize the individual that might be going through a crisis, right? And
Mm-hmm.
then be able to work with them so they can continue remaining housed in the community and also prevent homelessness, right? So recovery
Right.
is not linear. And so this little mobile team actually helps in terms of stabilizing individuals who are the most high risk, and that goes based on a clinical framework. And I could expand that later on in our conversation, but that's really in a nutshell in terms of capturing the most high risk clients to help them stabilize and continue living and thriving in independent scatter site model of housing.
Wow. An interesting model to say the least. How 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 does housing connect like differentiate from like traditional supportive housing models? I mean, you kind of touched on it, but could expand on that a bit?
So yeah, so the difference between just the standard like housing model and scatter site and Health Connect is that one, the unfortunate reality, this is more of a systematic and funding
Mm-hmm.
aspect, is that we only get funded X amount of dollars and they want us to, you know, like change the world with it and end homelessness, right? It's
Mm-hmm.
so with that being said, is that we actually get a contract, whether it's federal, state, and city, and you have to pay rent and everything that comes with it and staffing and with that being said is that the caseloads are high, let's be real. So if you have a
Mm-hmm.
census of 100 clients, right, in a program, you're talking at least the case managers who are not clinician, either at a BA or an associate level or have experience. You're talking about 20 to 25 clients on your caseload. And with that being said, there's not only the case management piece, right, of meeting and
Mm-hmm.
doing home visits, it's also unit inspections, it's also all the documentation, it's also helping the client in terms of moving, turnovers, landlord, repairs, you name it. Case managers do a lot. I always say that case managers are very crucial to the work that we do, um, and I always am highly valuing case managers because of the level of work and complexities that they manage. With that being said, is that there is not really a specialized clinical team that's multidisciplinary, like having a nurse, having an occupational
Mm-hmm.
therapist, having peers, having social workers, also having an LCSW to do the clinical assessments and the clinical work, and being able to work with the clients who are high risk in terms of those areas from a clinical lens and medical lens and peer support and taking time with the clients. So if the team has to go meet a client this week and follow up next week, we do that. They go out to
Mm-hmm.
the community and meet with the client for follow up. They are there present also for the discharge planning as well. If someone is in the hospital, we visit them, we connect them to care. We are part of the care plan where there is no service gap, which actually happens and gets lost in translation, where we have many people who go in and out of hospitals, get lost in the system.
Mm-hmm.
They give you a referral, as you know, they don't
Yep.
show up, there's no connection, no one's following up. And if you have either ACT or you have a APS, or when you call mobile crisis, what do? They knock, no one's there, then what happens? Case
Yeah.
closed, right?
Right.
So that's not the case with Health Connect. We follow the client from beginning, middle to end. So
Mm-hmm.
it's a whole process. And because we are, dedicated to have that continuum of care, we also connect with their providers, whether it's internal or external in the organization, to provide that level of care and bridging the gap, which actually happens. And then you have individuals that, what happens? Go in and out of hospital, lose their housing. We want to prevent evictions, right? We need to
Right.
assist the individual with applying either to one-shot deal, court, and whatever it is. That's where this team bridges the gap in terms of services.
Cool. Um, how do you guys deal with slumlords? Because when I was doing supportive housing, there was, especially in Brooklyn, there was so many landlords refusing to do repairs, and like like you mentioned, got like severely mentally ill clients living. Got there's housing programs who work specifically with adults living with HIV, and how do you deal with that?
So yeah, I mean that's a good question because that's an ongoing aspect of working with landlords who, I mean, that's the only name you could call them, right? Like slum landlords and all these open violations and having to struggle with repairs, which is what the case managers struggle with, the program directors, the supervisors. Look, I've been on calls too, going through the working in housing and up on this level is that one is, look, there's a couple of things with this is that one, we need to have better relationship with landlords and for landlords and management companies not to view people who have a mental illness, like something's wrong with them, or they're less than human, because that's what it comes down to: less than
Mm-hmm.
human, formerly homeless, unstably housed, SMI, substance use,
Mm-hmm.
medical, you name it, right? All the
Yeah.
check boxes, right? It's
Mm-hmm.
first really starting with their own biases and views on like the whole aspect of homelessness. Everyone deserves a home. But here in the United States, which I've actually spoken in other podcasts, it's like the lowest of the lowest. People see you like nothing, which
Mm-hmm.
shouldn't be the case, because we're all humans, and at the end of the day, everyone deserves a home. Two is that the repairs in terms of ongoing repairs, I always say this: look, this is a business. We pay money for the rent. The expectation is for them to do the repairs. Does it happen all the time? No. So that's where you have other steps that you actually incorporate. One is ongoing documentation, certified mail, pointed it out, and then if it has to be that you have to stop the rent, not that I'm advertising that, but you have to sometimes hold the rent until the repairs are done. Right? That's the only way things kind of move. And then other times what happens is that, yeah, they'll get their rent, they'll do repairs, and then well, we'll pay the rent, is that sometimes they don't even want us. They don't want housing
Mm-hmm.
providers because, oh, people in the community are complaining, oh, I could get more money for my buck than what a program's paying
Mm-hmm.
for rent. And so that leads to, again, screening us out to rent these apartments. So
Right.
that's an ongoing issue that I really think it's at a higher level in terms of really holding these landlords accountable and delivering what's expected of them, which is, just decent housing. It's not Fifth Avenue, Lower East Side housing we're
Right.
asking. It's just decent aspects in terms of someone living in a decent home. That's what it comes down to. And so having this team helps the client to, one, have support to be able to work with them and stabilizing them, but also advocating for them, right? Where the case
Mm-hmm.
managers have done everything more at a higher level. And so, with that being said, we also, this team also integrates a whole health model, which is of the organization, more of holistic, not only the traditional aspects of Western medicine. And so, the team, it's been since September 2024, really, that has been launched. And now the team has been building up. They go to Manhattan, they go to Bronx, Upper Manhattan, Brooklyn, and Queens. So it's mobile. And in addition to that, we're like collecting data based on our framework, which is what I kind of lightly touched when you said what makes it different, is that we have a clinical framework um that we created, and it goes by priorities, right? So if I'm what is a priority one? So a client that's actively hallucinating, actively using, has had several overdoses, in and out of incarceration, hospitalized several times for psych and medical, that's a priority one.
Right.
That client is a priority, and we need to meet as a team with housing, with Health Connect, and the providers and the client being part of the process. Then you have priority twos, which is, less, and then priority three. So there's a whole model of a clinical framework that we go based on how do we identify the most high risk, right? And
Mm-hmm.
then what data do we want to capture and how people are improving, which is one, reduction of hospitalization, overdoses connected to care. And then really like the model of framework and the program is not intended long term. It's more of a 3 up to a 9 month period where this team will be working with the clients. And right now we have roughly around 147 clients, or tenants, better yet, and they could actually serve up to 300. So it may fluctuate in terms of the level of care and involvement, but this is not something that it's long term. It's more of a preventive, short term diffusing, diffusing in terms of emergencies, and also in terms of being involved to that degree, because like I mentioned, as you know, recovery is
Mm-hmm.
linear, and someone's
Right.
not always going to be high risk, right? They're going to be
Exactly.
stabilized to then really just be living in terms of, I don't want to go too clinical, baseline or the liberal
Mm-hmm.
habitability of it. But with that being said, is that's really like the framework in terms of data collection, and also just to wrap in terms of Health Connect, is that this is a two-folded program. So yes, it works with the most high-risk individuals and crisis management and everything that comes with it. It's also, and it's not like ACT, it's not an ACT model. It also serves as point of entry when someone is, moving into a housing or for the first time having a home or lost their home or whatever the situation is. They're going to be working with clients at point of entry and assessing what level of support they need of wraparound services, and then work with them for a period of 3 up to 9 months in order to ensure that they have the resources, they feel connected to their housing team, that if they need any type of service, that they can be that liaison between the housing team and their service providers. Because what has happened and does happen is that people move in, get lost with the system, right? I'm not familiar, not connected to services, and what happens? They start deteriorating in terms of their mental health
Mm,
and terms of their recovery of substance use or whatever else is going on. And then we're dealing at a crisis, right? So we want to be
right.
also preventive and not only work in crisis mode.
Gotcha. That that really sounds like a good model because as you was talking, I thought about ACT, but I'm glad you like it's not ACT. So
It is not because when I started like working on this with the first job description and then the name and everything, and then I was like, this is not ACT. This is not an ACT team. I want to make this very clear. This is a two-folded program where we'll capture not only working with high-risk clients that are going under crisis, but also being preventive at point of entry. Because like when a lot of people move in housing, they get lost in the system. In the system of housing, they get lost.
mm-hmm,
Unfortunate. And so get disconnected to care. And so this team will actually help, individuals integrate into housing and have that social and all the wraparound social support and wraparound services they may need. Because many individuals, this might be their first home coming from a psych
right.
hospital, right? Or chronically homeless and things like
Mm,
that. So, yes, that's the difference. And I'm happy because we don't have a team that I know of in the housing world that helps individuals at point of entry and then the continuum, and then also at the same time addresses high risk clients who are currently housed and stabilizing them.
oh, yeah. So, and also you got to deal with like you mentioned it could be like their first apartment and there's like
Mm-hmm.
the self sabotage is real. Is like they're you try to get them stable, but they're not used to like actually being stable. They're just so used to the their chaos of their life. That's all they know, and like you know you try to like no, you got to do it this way. It's like
Correct. And can I just add to that? Because you brought up something important, Beth. So, like, one is this might be the person's first home, right? Or they've been evicted in the past, and then no one has really, like, taught someone to do financial management, right? Teaching
mm,
financial management, teaching about upkeeping of the apartment, noise control, nuisance, and living independently. Like we all have to be taught, and many of the individuals, who are unstably housed and chronically homeless, they may have not been taught in terms of the importance of paying your bills, right? And money management, and not even that. Let's say like even us, right? Like no one had taught me how to manage my money. I had to learn on my own to a certain degree. They always said, "Oh, you
mm,
gotta save money and pay your bills," but these are things that we kind of assume it's automatic, but it's not, right? And
mm,
so, how do you maintain your apartment hazard free and not hoarding, right? Because a lot of
mm,
people, the hoarding is real, and so
yes.
and it is a mental illness, and how do you manage that piece, right? How do
Mm,
you eat healthy? How do you maintain yourself? How do you pay your rent so you don't become evicted? So This team, Health Connect, will help individuals integrate into housing. So we have from the beginning, okay, I need to pay my rent every month, keeping the expectation in terms of habitability, especially with roommate situation, right? How
Mm-hmm.
do you respect your roommate and the space and everything? So, and really helping people to thrive in the community and not set them up for failure, because we automatically think like, hey, we got someone housed, that's great, that's a checkpoint, right? But
Mm-hmm.
are they going to live independently and safe and thrive in the community? That's a completely different check or bucket.
Right.
How do you measure success? Is it only by placement, right? And then what happens? You place someone, they're not doing well, they get lost in the system. What happens? They go back into the shelter, right? So the whole
Mm-hmm.
recidivism, which I don't even like using that word, that whole cycle of in and out,
Mm-hmm.
coming out of shelters or unstably housed is real. So having a Health Connect team, from not only, the crises aspect, but point of entry will help individuals in terms of really being able to thrive and long-term prevent homelessness, other than the whole cycle of in and out coming
Right.
from shelters.
Mm. What lessons from the Housing Connect program can be applied to other supportive housing programs aiming to integrate behavioral health services?
Well, that's a good question. I really think that this small innovative team that came from an idea and a service gap for a long time is that we need to, and this is more at a high level aspect of funding, and really, um with everything going on, is really investing in terms of helping individuals to thrive in the community in addition to housing, meaning the supportive services, right? Needed. Behavioral health care services is really needed and needs to be more embedded into housing other than kind of being separated. And now I'm seeing, like, I don't know if you're seeing this also, I'm seeing a change where now they're talking about, oh, behavioral health housing. And I'm just like, oh my goodness, now we're talking about this when this should have been talked about years ago. It's kind of like silos of pockets. You have
Mm,
the housing piece here, then you have the behavioral health care services here, and everybody's just like in all these buckets, right? I consider that one, this needs to be more invested in terms of taxpayers' money in order for individuals to have behavioral health care services, wraparound services that are accessible, that are equitable, that are culturally, competent to the population that we service, and that it really doesn't take all this money like people think, to have these
mm,
small little teams embedded in housing. This whole Health Connect program is running under $500,000 for a team to do the level of work. And so I really consider that if we invest more dollars and embedded in housing for behavioral health care, it really will address the bigger issue, right, of
mm,
maintaining people living in the community independently, being able to thrive independently, and also preventing homelessness and the whole aspect of in and out of shelters. With that being said, it's something that, again, it's an investment to the clients that we serve, to our community, to everyone, as society at large. And so really taking that approach of more of longevity, preventive than crises mode, because of what I'm seeing is that's always like a crisis, right? In housing crises,
mm,
everybody drops the ball, and I'm like, why are we not more preventive? Of
right.
taking more of that approach of really thinking outside of the box, and how behavioral health care is important for individuals with disability and chronic homelessness and unstably housed. It's the only way that it could be successful for the population that we serve in order of wraparound services that are much needed.
Gotcha. How can no, you touched on the political aspect, touched on it a little bit, but how can policymakers and stakeholders support the replication of such integrated models on a larger scale?
Yeah, I really, so to all, council individuals, not trying to get into politics, but I always say, like, social work has a political, has a lot, an influence in the political area,
Mm-hmm.
is that one, we need to really, like, take these small innovative programs and really invest in service dollars. Also being able to like cross-section partnerships with not only with government and city council or with funding source, also with providers and advocates, right? To be able to really address and create address the problem of homelessness and behavioral health care, right? And also being able to, work together in terms of building out more services, because we talk about housing, but we need to talk about services, support services, and behavioral health care. Also bringing more, sharing data. So we'll be presenting at the network conference on Friday, and I'll be presenting, including the rest of my team, in terms of data of how this works. This is not just talking about model, this is data collection in terms of how this small team has been effective since September 2024. So we're talking about what, 7, 8 months altogether in a short period of time with 147 clients, in terms of that an investment of 500, $600,000 is worth it than having the whole, in and out of shelters, spending
Mm.
millions of dollars of people
Right,
going
exactly.
inside of the hospitals, and being able to build that model that's embedded not only here in scatter site at ICL, but really across the board, embedded a model that is sustainable across the board. And so it's like, how can this model of practice be embedded more in housing, and that it can be successful, number one, in helping people recover and sustain their housing, but also how are we reducing taxpayers' money, right? Everybody's saying, oh, we need to cut because we're spending billions of dollars. I don't know from where, like Orange Head would say, but I would say like, hey, we spent X amount of dollars and we're saving the state and the federal government and the city X amount of dollars. So with that being said, I think this is really more of a high level conversation in terms of providing the data that works, the model that works, and that the investment is worth it compared to, what's been going on or not going on in terms of this model of practice.
Yeah, yeah, it's so important. You're right about the the millions of dollars that are spent just to people going in and out the hospital, shelter system, instead of just doing preventive like you guys are trying to do from the jump. And since we're talking about policymakers and stuff like that, uh, being a native New Yorker, I know you live in Jersey. Like, go vote this month
Mm-hmm.
for the primaries. So the New York got a mayor's race, and Jersey got a governor's race. So go out
Yeah.
and go vote, because every vote should count as big races. And I'm a native New Yorker. My bias, New York make the whole country, make the whole world go round.
Yeah. And you're right. Look, we also have primaries here, and we have not only in terms of the governor in New Jersey, but also in terms of local townships and things like that, is that a
Mm,
vote counts. Our vote counts, and we need to make the change, right? Because if we don't vote, people say, oh, it's just a vote. No, a vote right now in the political environment, as we all know that we're living in, is do or die. And
mm,
so, with that being said, every vote counts. But yes, we need more investments of behavioral health care services embedded into housing. Housing alone doesn't resolve all the issues that goes on. Housing is part of the recovery in terms of everything that comes with mental health, substance use, medical, right, and social support. And so, we work with the individual, it's housing, but then with all the wraparound services. If someone doesn't have those wraparound services or that level of support, at one point they're going to lose their housing, right? Because they're either
mm,
not paying rent and not doing well. So, a small team, and I don't want to call it small right now, it's 8, and we want to expand more. A team like Health Connect is now producing data in terms of how this team is really invested in terms of helping individuals be stabilized and thrive, but also how effective it is when it comes to embedding it more into scatter site model of housing.
Cool.
And just to end that loop is that how we're actually funding this is we receive OMH RTS dollars, just an enhancement in terms of our rate. And so what better use of the dollars, right? Taxpayers' money to create a team like this. So the money is going back into our clients, back into the community in terms of, you know, a clinical enhanced team in scatter site. So it's going back to our clients, invested into the community. And so that's something that really pride where we're using taxpayers' money in a good way.
Cool. And shout out to the Office of Mental Health from New York State to do that. So, uh, where 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 can people reach out to you?
So you could find me on LinkedIn, Rosita Marinez. I'm the only one, so that's why I could say you just type in my name and you'll find me. And also actually on Instagram too, Rosita.Marinez. You can find me there. You know, feel free to reach out to me too. If you have any questions, any ideas, how we could collab. And again, this is a bigger systematic issue. I really consider that having more community members and partnerships, you know, more city council involvement, you know, federal, city and state involvement, and really people with lived experience, more social workers and stakeholders, like we could create more of these Health Connect programs embedded into scatter site housing. And I know a lot of my colleagues and providers always say, oh my goodness, scatter site is so challenging and complex because of the model. Health Connect, having a Health Connect team could could help individuals to continue living independently and really decrease incidents and everything that comes with it.
Cool. That sounds great. Always a great conversation with you. And I'm sure we could talk about housing in New York City for like hours. So much, so much happening, city, state, federal level in terms of housing. So maybe we could come again, being like number six.
Thank you. I really appreciate the invitation, and it's always great conversation with you, Baz.
Absolutely.